Given that you've commented on the high prevalence of the problem, I'm surprised, maybe this is happening, but I'm surprised that I haven't heard more about Big Pharma trying to find a way to find a solution.
Yes, and they did look at it, and they came up with the dopamine agonists, which they already have for Parkinson's disease. And as I said earlier, it was fantastic. It worked, and I still use it as a diagnostic process. Give them 1 or 2 tablets, and if they come back and say, it got rid of my RLS, then great, it's a good diagnosis. But we then discovered this condition called augmentation. And augmentation is a worsening, a deterioration in the RLS, which is triggered by taking treatments for it, particularly dopamine agonists. So you had these people who were given the drugs, felt they were absolutely brilliant, and then it came back far worse. And that is now a big problem. Interestingly, the NICE Clinical Knowledge Service still puts it as one of their first-line medications. That's rapidly getting out of step, because if you look at over in the United States, it is moving away from being first-line. And there's a guideline being built over in Europe, and again, it's likely that dopamine agonists will disappear as a cause. And I think pharma have become, having had their fingers burnt, have become more reluctant to put the research in. But I agree with you that if you look at the other drugs we've got, all the things we've got are things that were used for other conditions. And so the main first-line drug at the moment, certainly in Europe and the United States, are the alpha-2 ligands, the gabapentin, the pregabalin group of drugs. They have their own problems, but at the same time, they don't cause the augmentation. And the other one that a lot of people are having is opiates. Unfortunately, the opiates that are best at RLS are the ones that we get told we mustn't prescribe because they're addictive. And so, for example, oxycodone is one. And in the United States, they use a lot of opiates, which we wouldn't really touch, the sort of things we use mostly for addiction.
Right. Is there a balance there to be struck? I mean, if somebody's having unbearable RLS, surely it's worth giving them those opiates?
I personally agree, and I will do it. But I have had the phone call from the prescribing advisor at my local ICB saying, why are you prescribing these drugs? We had one patient actually who moved in who was on methadone. And everybody in the UK thinks methadone, addiction. And so I prescribe it. I get a phone call saying, but you're not an addiction specialist. Why are you prescribing this drug? And I said, well, it's a restless leg syndrome. And unfortunately, the prescribing advisors don't know anything about it either. And so, yes, it's a bit of a problem. We have to have a balance. Interestingly, the opiate doses, both methadone and oxycodone, are much smaller than are typically used for things like back pain and so on, if you are using it for that. And we don't seem to see, and I'm touching wood frantically, the degree of tolerance developing with it, probably because the dose is small. And it's indicating that it's not a pain relief effect, it's a different effect that's happening probably on the brain to actually reduce the symptoms.